Well, ipilimumab was the first adjuvant therapy shown to clearly prolong survival in patients with resected high-risk stage 3 melanoma. Clearly had an advantage in recurrence-free and overall survival, no question about it, which led to its approval by the US FDA back at the end of 2015. In contrast, it's a relatively toxic regimen given at 10 milligrams per kilogram. It definitely has efficacy, but as a regimen, because of the side effects, it leaves a lot to be desired. That was the reference arm, the control arm, in the CheckMate 238 study, where, as you know, there was clear benefit for the use of nivolumab compared to ipilimumab. But ipilimumab can be a useful regimen, to be honest, because of the approval of nivolumab in the US, and I assume in the EU and many other countries. I suspect the use of ipilimumab as an adjuvant therapy is going to go by the wayside. It would certainly be useful in someone who failed nivolumab, was re-resected, rendered free of disease again, and was BRAF wild type. Then you have very few adjuvant options. And yes, I have used ipilimumab in that scenario, but it's really, in the US at least, where it has its only approval, it is not used very much at all. Well, if you look at the data from CheckMate 238, we're talking at 24 months, 60-some-odd% rate of recurrence-free survival. Relatively few, if any, patients have actually died in that study. If you look at the data from the abstract that I'll be presenting on Monday, there have been no deaths on the nivolumab arm. There have been 5 deaths on the ipilimumab arm. Do the mathematics, those are very small numbers. We're not arguing that there's a survival advantage yet, but it looks pretty encouraging. But patients with stage 3B, 3C, 4 melanoma will generally, if we had a placebo arm, would have well less than a 50% rate of recurrence-free survival at 5 years. In fact, at 2 years, it would be 50% or less. So those patients are bad actors. If you take the entire group of stage 3A, B, C patients, because the 3As can do very well, that recurrence-free survival changes, it improves significantly. But again, the 3A patients were not included in the trial I'm reporting on, the CheckMate 238 trial. But if you put all the stage 3A, B, C patients together, then you're looking at probably a 50% 5-year survival, which is heavily weighted to the 3Bs and the 3Cs. The 5-year recurrence-free survival for a 3A in the current staging criteria is probably 70 plus to 80%. Well, the 238 randomized phase 3 controlled with an active control double-blinded study was to determine and compare the recurrence-free survival between the treatment arm of nivolumab and the control arm of ipilimumab. And secondary endpoints were the overall survival. An exploratory endpoint was distant metastasis-free survival. And of course, there was an assessment of toxicity, comparing them between the arms, and quality of life using an EORTC validated quality of life instrument. So those were the aims and the endpoints of the trial. Well, the efficacy findings originally presented 8 months ago, when there was about 18 months of follow-up in all patients after finishing treatment, suggested there was a clear benefit in terms of recurrence-free survival and even in distant metastasis-free survival for nivolumab as adjuvant therapy in the resected stage 3B, 3C, and 4 population compared to ipilimumab. And not only was it more effective looking at the primary endpoint of recurrence-free survival, it was a heck of a lot less toxic. If you look at the key endpoint, which I evaluate and talk to patients about, which is the likelihood that you're going to stop therapy because of side effects related to treatment, 8% for any grade treatment-related adverse event for nivolumab versus well over 25% for the use of ipilimumab. So no comparison. I mean, a much less toxic and more effective regimen. So you can't go wrong, which led to the approval of nivolumab in the US as adjuvant treatment for any resected stage 3 or 4 melanoma in December of 2017. Well, ipilimumab was used in the original regimen that was reported out from the EORTC 18071 study back in 2016. It was 10 milligrams per kilogram. And there are various reasons why that relatively high dose was used, but suffice it to say, it's a fairly toxic regimen. A third of the patients will stop treatment because of toxicities, 41% of rate grade 3-4 adverse events. Compare that to nivolumab as adjuvant therapy in the 238 trial, 14 or 15% rate of grade 3-4 immune-related adverse events, 8% rate of stopping because of toxicity. No comparison. Hands down, nivolumab is a much better tolerated and much less toxic regimen.